All right. Welcome back. Thanks so much. Let's dive right in. So on your table, and I apologize, I don't have enough cases for every table. So just lean over, talk to a friend, we're going to get close here. But let's explore some real equity cases from across our APA member health systems. Again, in the spirit of Otto Scharmer, we're going to ask that you keep an open mind, and we mean be open to new studies, new facts you may learn in the case. Have an open heart, be open to the stories of the real patients that we're going to talk about today, and then maintain an open will. And for us, that means resisting feeling discouraged and instead diving in and trying to see if there's something that we can do. So as you're in groups, you can begin exploring case materials in just a minute, but hold off on talking about solutions. We're just looking for the opportunities to advance health equity. You should have a little cheat sheet as well that'll be on your table, but it'll look like this. Just some reminders of what we want to look out for. Intersectionality, remembering that no group is a monolith. Inclusivity, who is at the decision-making table and who is being overlooked. Social drivers of health, we sometimes call them social determinants of health, economic drivers of health, things like finances, cultural norms, and societal attitudes. And then opportunities to partner. We talked about this earlier. No one hospital can do this alone. So remember your partner organizations. So we're going to start here with building empathy. So for 5 minutes, in each case file are real equity stories from across APA's footprint. As a team, open the case file and read your challenge story. 5 minutes. All right, so hopefully now you've just gotten to read it one time. So now we're just going to take 5 minutes individually to reflect on the case. There's some sticky notes. Feel free to write down, keep my marker if you want to, write down as many thoughts as come to your mind in the next 5 minutes, details or initial impressions, but again, not solutions yet. All right, so now it is time to move on to discovering opportunities or looking for solutions. So let's not do this individually. You can do this as a group, but you want to get down as many different opportunities to champion health equity that you see in that case within the next 10 minutes. And don't think about feasibility. Do not think about budget. Do not think about political will. That is way down the line. And do one idea per sticky note because we're going to rank them. As you're thinking about your opportunities, there's additional data in that file. So there's information that we would be using, summaries of research studies, information about the linguistic outline of your community, things like that. So anything that is in that folder that will help you make these decisions, go ahead and take a look at those. All right, I hate to cut you off, but you can continue discussing. On your table, you should have a scoring matrix that looks like this. And you're going to use this to rank the opportunities that you've identified by impact and feasibility. So things can have a high impact and they might be really easy to do, or they might be not so impactful and be super hard to do or cost a lot of money. So for each of those sticky notes, just go ahead and put it where you think the opportunity might fall, and then we'll talk as a group. All right, so hopefully those discussions and the cases were interesting. So now I want to learn from each other. You all got different cases. So if we could take 5 minutes per team, if possible. Yi-Shen's going to run the mic for us, so for the sake of the folks that are digital. And if as a group, one person could share the case story briefly with the team, and then also share some of the potential opportunities that you identified. And you can share all of them, or you can share the ones that you think are the tops that you would really suggest to your C-suite leaders. So no rush to go first, but if you don't volunteer, I will just choose any first team to share what was your case and what were the opportunities that you identified. Well, let's choose team one. Who had case number 1? Is this over here? All right, let's start there.
German female voice.
I knew we would get picked. Okay. We are case study number 1. It's a 22-year-old male who came to the ED, and he is Spanish speaking only, self-employed, uninsured, and he came a while ago to the ED with a cyst on his hand. They said, okay, gave him antibiotics, sent him home. Cyst didn't go away, came back several times, and now I think it's the 3rd time to the ED. They did a biopsy and it's malignant. And so the question was, what are the least impact? What could they have done to make a difference? And we came up with, what about trying a translator? At least the one on the iPad, which is a virtual translator that we are using. Try to find out and communicate with the patients, at least try. And then we thought, community resources, hook them up down the road. That's down the road, not with maybe ESL second language. And the patient really didn't have the agency to self-advocate for himself, educate him and encourage him to talk about it. We've also found there's a loophole because he didn't have a primary care. So we thought, well, we could hook him up with a community resource where we have a primary care on a low income basis. And like in Washington State, we have a system where he could get health insurance, even if he's documented or undocumented, he can sign up for a very low cost healthcare where he could access primary healthcare and from then on care on.
Yeah. That case is really an interesting one. And it illustrates how just because it's not our fault doesn't mean it's not our problem. So that patient presented at a different community hospital, not an Adventist hospital, repeatedly. But by the time he got to our ED, unfortunately, he was much farther gone. So just illustrating how, the community doesn't really care whose fault it is,
And we thought the ED is to save life or limb. It isn't. And so that is a primary purpose of an ED. So if they come with a cyst and think, right, oh, this is major, you just have a sniffle sort of in comparison. So that's not very high on their radar screen.
Yeah. Thank you. Any volunteers for the next group to go or comments on that case? Okay, so if not, who would like to share the story next? We can go in numerical order or, yeah, okay. Number 2, let's do team 2. Or you're 3? Who has 2? Paul Sox, I think is 2. There we go.
So in this seminar about racial and ethnic bias, they asked me to speak because of my accent, and that was really just monolithic and quite divisional. So I just want you to know that up front, okay? Although they did think that maybe it was more authoritative, so they tried to butter me up that way. So we had the case where basically, in this COVID times and post-COVID times, finance decided that we needed to stockpile certain tools needed to fight airborne diseases. And so looking to be able to source pulse oximeters, talking to other finance people to find out where can they access them at the best rate and so forth. What they became aware of was that pulse oximeters are less effective on patients who have more melanin in their skin, so therefore don't give an accurate reading. And you would think that maybe it might be the light go through, so therefore it would be different. What it really means is they actually report as higher oxygen levels rather than lower oxygen levels, which is the wrong way around, just in case you didn't know that. And then people with more nail polish or jewelry or other things don't necessarily place it correctly. And also that the FDA currently requires, has no requirement on medical devices to be tested on non-whites before approval. And so then the discussion came is that the finance person went to speak to other people in finance about how to handle the situation. So now you're beginning to look at do you have the right people at the table for this conversation around, as well as the monolithic sort of system, and then the systemic, biases that you're putting tools out there without any really warning or informing people of the biases. So the things that we sort of looked towards was that there was I've got to read other people's writings here, broaden discussion beyond just the finance group, but also maybe education around the population. To that, if we couldn't change that, let's at least let the population know what are the symptoms and things that you should be looking for in yourself or other family members that give you a warning that you need to go and get the proper blood test rather than dependent upon this. So that may be a quick fix to at least get people to be aware of what symptoms. Also, a little bit of an education process around the providers themselves to make them aware of the inadequacies and not to be dependent upon that. Most of us, when we walk in the hospital room, people have one of these on their fingers, and you look up and the nurse is just constantly taking down the vitals without ever considering whether or not this is a bias or other methods around that. Of course, the other issue of this is that to do the full blood test is much more expensive. And how often are you going to do it? And are you going to be reimbursed for it? It's other factors around that. Some of the longer term sort of things that we looked at was also the role of advocacy in this as well. And I was just saying, from my experience in international development, we all go out there and we do things in communities, but actually it's advocacy which changes public policy, which has more impact. And in this case, it's really about doing more advocacy. We have FDA and other agencies to say, if you're going to bring out equipment, you've got to look at all the biases and so forth, make that a requirement around some of these things. And I'm just trying to look through our notes. I think we've covered enough there.
Yeah, thank you. That's always a shocking one, and certainly a big challenge coming out of and continuing to deal with COVID. Any thoughts on that case? And if not, we'll move on to team 3 or case 3.
So I'm going to present the problem, and a colleague here is going to present all the answers. So our case is that we are talent management, specializing in executive recruitment and retention for our hospital C-suites. But our hospital C-suites leadership is there's a lack of diversity. 100% of the leadership is white and non-Hispanic, and 85% of the C-suite is male, and everybody speaks one language, presumably English. So the challenge we're facing is that to be considered for candidacy, there is a pretty high experience bar as well as an education bar. And then whenever somebody who is not white or male or not white, they leave within a year of onboarding. So that's the situation that we're trying to address.
So we discussed several opportunities, some first being around the budget and the leadership and ensuring that there's budget and focused leadership, looking at the different opportunities. Also, senior leadership education on the impact of diversity on the health outcomes. There was some facts presented to us about improved health outcomes with increased diversity in the workplace, as well as their own personal bias and how they may be contributing to a culture or atmosphere that contributes to that high turnover rate in the first year. Leadership relationship building was something else we discussed, that idea to, once the leaders have had the training on how their own biases may be impacting things negatively, to then also reach out beyond your normal social structure and build those relationships within the workplace. We talked about understanding and leveraging the turnover and promotion data, in particular from a gender and diversity perspective, and looking for attrition from the career pipeline to understand where fallouts, well, not to understand, but to begin to understand where fallouts may be occurring. Wage structure and identifying a clear wage structure and equity audits to identify those opportunities, flexible shift and childcare, and then finally a paper ceiling audit, similar to a glass ceiling concept, where you look at the degrees required and the experience required to understand if you are accidentally setting a bar that is unnecessary.
Yeah, I love that. I think every Adventist health system in North America has their hand in education in some way. And what we're finding is that there's what they call a leaky pipeline. And it means that, yeah, you can get diverse candidates in, maybe in a high school STEM program, and maybe even to a bachelor's degree. But the higher that you go, the more they drop off. And we have to figure out why that is, why they cannot get to that point to where they can have a leadership role. So thank you. Let's do the final case.
I was picked because I know each of them, and so they all pointed to me. So our case was, we were a pastoral service, and we have been inundated with a lot more of requests for support from our teammates out there. Clinicians are feeling discouraged, tired, and hopeless. It seems to be that the requests are coming mostly from some interesting areas: labor and delivery, epidemiology, and case managers, as well as corporate. So part of, I think, our task was trying to find out why this is. Was there some event that took place that caused a spike? Was this a reflection of who these people are? Some of the data that we got, the extra in our folder, indicated that in healthcare, those who are in patient care, like PCA positions, MA, LVN positions, may be people of color more so than those, again, who are maybe higher up in the ranks. So is that what's causing the distress, or is it the people they are caring for? We know that there's large higher maternal death rate in those of color than in those who are white. So is working in that environment and seeing that disparity causing the distress for these folks? Are the case managers feeling like they know the things that their patients need, but they can't get those resources? So we had many questions. So the first thing we thought, we need to find out really where is the distress coming from, and either reach out to those individual departments to get more information, get better data so that we know how to help them. There were some supports at the hospital, but the question was, are those adequate? Are those filling a need? Do we need to get rid of those and produce some others? Is this a leadership problem? Is that why these seemingly disparate groups are having difficulties? So we wanted to really do a lot more investigation. Obviously, it'd be great if we could hire more pastoral care to reach out to folks. That's kind of a high impact, but also a high, not very feasible in many situations. So lots of funding issues and hiring issues. And I think those were the main highlights that we had.
Yeah, thank you. That one was, I found myself reflected in that case a lot. I talked a little bit about serving during COVID, and at one point, maybe like 2 months into the height of the pandemic, I found myself laying on the floor of my home office. And thankfully, I'm at Advent Health, and we have a pretty robust pastoral care team there that was able to get me the care that I needed. But part of that despair came from seeing my community reflected in the data every week and hating that I had to say every time, once again, Black death is significantly higher than the rest of our patients. So I thought that one was a really important one. Thank you. So we want to move from the case a little bit just into some discussion, and then we're going to wrap it up. I'm going to put this up at the end. This is both a QR code to our health equity reading list at APA. I promise it is quite brief, but one of them in there does include a course out of Johns Hopkins where you can get some continuing education if you'd like, but if not, it's free. And you can click through and learn more, as well as some of our previous work, some of our recordings with the ABC on this issue. And then second, I would be remiss not to plug the work of my team. The Adventist Health Policy Association has a policy brief where we talk about issues in health policy. So if you liked any of this conversation, if you want to read more about that, they are very short and they come out every other Friday morning. They are they are aimed at directors and above in healthcare leadership, but it's open to anyone. And then I'm going to put this back up so you can see it. But before, I also wanted to let you know that you're not in this alone. APA has started this work and is continuing to support, and anything that we can do to support you in this work to advance health equity, we want to do it. So we have a plan for advancing health equity. We also have 5 Steps to a Healthier America, which has been revamped. It's on its second version, so you can visit AdventistHealthPolicy.org as well to get your hands on that one. And then with that, we can talk if there are any questions, and if not, I'll let you go. So Yi-Shen, I'll open it up for any questions either about the case or health equity more broadly.
Cherie, thank you very much. What about AHPA's involvement in issues that are highly politically charged and sensitive? And those, you're in Florida, I'm based in Florida. We face floods of legislation that impact everything you just talked about for the last hour, that impact the access to various kinds of care for marginal communities. Is there activity on those areas?
Yeah. So there is, I'll say that we do pick and choose our battles. So at APA, we have a very large footprint, and some of them include lawmakers who just honestly are not interested in good faith conversations. They are not. And so for some of those lawmakers, we, other than providing educational materials, we sort of conserve our energy. But on the broader issues, what we do instead is take it to the federal level. This is not about politics. It is about public health data and best practices. And that's where we try to have to be the adult in the room, to come with the data, to come with the best studies, and to say, let's not deal in feelings or even in my specific lived experience. Let's take it to the literature. And so that's how we handle it. And we haven't had to shy away from any of those hot button issues because as healthcare providers, we are anchor institutions, and we find that when we walk in the room, sometimes we can advocate for equity in a way that a community-based organization that is seen as either right or left-leaning cannot. Yeah, of course. Good question.
I can talk really loud, but I just wanted to see you run. So thank you so much for this great presentation. I think one of the controversial topics that I'd be interested if APA has delved into is risk reduction in substance use. And we know from a public health perspective that places that hand out clean needles, that are actually places that people can come to use drugs, actually reduces harm. It keeps people alive until they can perhaps get help. Any delving into that?
So we are starting to learn more about how we can do that, but we did get some early advocacy wins. So for anyone who does not know, you can purchase naloxone over the counter now. And that was something that we heavily advocated for. Now, granted, we have not gotten where we want to be because it's cost prohibitive. It's not as cheap as we'd like. We want it to be so that any good Samaritan can go $20, $50 and keep this in their purse to save some lives. We're not there yet, but that was a very meaningful advocacy win in terms of either needle swaps, safe zones. We haven't gotten there yet, but I got to get out to Henry Ford Health System and kind of learn from them and see, okay, how are you approaching harm reduction? Are there some learnings that we can take back to our APA members? So we're hoping to continue to mature there.
And I just wanted to give a shout out to APA because, as a church, traditionally, we try to say that we're not political, but the reality is we live in a political world. Absolutely. And so when we don't want to be political, we don't have a voice on anything. And we never really engage to advocate on anything. But actually, we're so comfortable being the hands and feet of Jesus, but we forget that Jesus used his mouth. Yeah. And so I think it's really important that we learn advocacy and understand the impact of advocacy and speak into things. So I'm glad that we're sort of pushing forward on that. So thank you for advancing that.
Yeah, thank you. We do hear some of that narrative sometimes. We return to Micah 6:8 when we do. We return to Jeremiah 29. Not just pray for the city where you are, but seek the peace of the city where you are. And we interpret that as APA to be advocacy. Yi-Shen, I think with that may be the last question.
Thank you so much, Cherie, for an excellent presentation.